So what I'd like to do is delve into the topic of cultural aspects of care. As a preface, I would like to say that I'm not an expert at all at this. I take this as a perspective of gathered information from different sources, including the American Geriatric Society that has produced many of the elements of this slide presentation, as well as input from others. And this is an evolving presentation, and we look to modify it over time so that we can actually incorporate it as part of a national curriculum that has been requested of us from the HRSA program for the geriatric workforce. So if I can have the next slide, please. The goals are firstly to recognize the impact of cultural and spiritual beliefs on health, both in terms of physical and emotional and behavioral elements. We first and foremost want to try to avoid stereotyping. It's all part of that patient-centered care that we talk about. And we also want to work to simplify healthcare messages and to align them with people's beliefs. Oftentimes in caregiving with Alzheimer's patients, for example, we always talk about going with the flow. And so it also is important, when we have cultural considerations, is to go with the flow. But firstly, you have to understand what that flow is. And then finally, we want to talk about programs and training that will help promote comfort and dignity to our Native American elders as they progress through the continuum of healthcare. And I'll also mention that you're going to see a bunch of paintings. I love to add imagery to our talks and presentations, both from classic and maybe not more modern painters. Here you can see Monet with the morning sunrise and the reflections. And so just, again, the imagery is that how can we reflect upon how we can do better with cultural sensitivity. Okay, next slide, please. So there's this real conundrum, there's on one side, we've got the melting pot concept of the United States. This is where, the culture, all cultures transcend differences in ethnicity, language, and religion. We're a melting pot. We're all as one people. And that's given rise to a little different perspective of multiculturalism, where the approach is more to celebrate differences and to recognize contributions of all groups to American society. So it's a little different angle or perspective, and I think, quite honestly, it's an interesting concept. I mean, I grew up with first generation immigrants, and I wanted to learn my father's native language, which was Lithuanian. And he says, no, you're in the United States now. You just speak English. And it was sort of like, good gracious. So it was almost a disowning of the heritage. And so that's one perspective. I'm not sure I agree with it, but that is the on balance of how we need to view these different attitudes that people might have, and again, respecting those different perspectives. Next slide, please. So this is a famous painting by Georgia O'Keeffe in her naturalism and focused on the southwest part of the United States. She also did a lot of flowers, and so you can see with this ram's head painting that there's also a flower, a desert flower in her sketch or painting here. So we want to reflect on the population trends that are occurring. So diversity in the United States is definitely growing. And in the next couple of decades, 1 in 3 Americans will be from a traditionally underrepresented population. And I think most importantly is that we understand that the therapeutic relationships that we build can be influenced by both the healthcare worker on one hand and the patient or resident in long-term care's cultural and spiritual beliefs and practices. So again, it's always like recognizing what we as healthcare workers consider and practice, and also to try to get a better understanding of what matters. Okay, so that's part of the 4 M's of always asking what matters to the older adult. Next slide, please. So we want to always consider how we can better develop cultural competencies. And you know, there may be some generational issues. Like when I went through medical school, this was never a topic of discussion, whereas now we have these topics integrated into our medical school curriculum. And so the idea is that we want to develop knowledge and skills, such as in the area of how do you best greet an individual. I had a Nepalese patient come into my clinic, and as best of my recollection, handshakes were not something that was encouraged, and rather just a folding of hands and a bowing as a contact. And so that was just perhaps some, you know, one concrete example. You also, in this process, want to look at both beliefs and behaviors and practices that might influence your prescription. So dietary restrictions. So there's certain things that people either avoid or use more of, and what are the health issues associated with those. And then an action plan is always to demonstrate respect. And I think one of the lessons that I learned coming up to North Dakota was to be mindful of a lapse in time to allow the older adult to respond to a question. And I'll just add to that sometimes how the older adult responds to a question may be indicative of their cognitive status. And so a lot of times people with memory loss will turn over to their spouse or family member and defer to them to talk. But that's not always an indication. And you can't assume that means that they're cognitively impaired, because sometimes cultural norms there would be a deferral, for instance, to the oldest son or to the oldest daughter. And so there's that deferral process. And so a lot of times you just have to recognize that and not always interpret that as meaning something else. And I'll just reference here with this painting here by Van Gogh. You can see the crows that are rising in the air, and that you can see the road in the middle of this painting just sort of comes to an abrupt end. And so it makes you wonder, is that this pathway of life, you know, where we come to the end, and, you know, what's beyond the horizon for us. And so these are always questions that we need to think about in our life journey. Next slide, please. Well, formality is always a concern. You know, do you want to be informal or formal? I think for first encounters, it's better to err on the side of formality and to greet the individual as Mr. and Mrs. and then their family surname. The formality is sort of suggested here by this painting by Max Beckman with his lovely tuxedo and very stiff-looking kind of guy. And I think we all try to downplay that pomp and circumstance, but by the same token, we need to try and be as neutral as possible. And I find that in clinics, some people like to be kind of a jovial jokester thing, and other people just go like, well, why is this guy making jokes of everything, you know, and they want a more serious approach. So it's better to start off with encounters with people in a more neutral fashion, and then to branch out from there, I guess I would say. Next slide, please. Also getting an appreciation for language and literacy. And the vast majority of the United States population, no matter who they are not proficient in healthcare literacy. And I always mention that to my medical students and trainees, is that, you know, if you start using medical jargon, people just aren't going to understand that. And so rather than saying we're getting an ultrasound of your, belly, or abdomen, even more commonly, you might say that, well, we're going to take a picture of your belly to see if there's anything going on there. So a little bit more generic terminology, and somewhat maybe less disarming. And so, like for instance, in clinic, we'll do a bladder scan, and I introduce it by saying, we're just going to see if your bladder is having some problems, and we're just going to use some sound waves to to see how big the bladder is, rather than saying, oh, we're going to do an ultrasound of your bladder to see if you're obstructed. All that kind of makes people sort of hair stand on end. So the other points here are English language as first language or second language. I have some people who quite honestly want to speak in English, but I know that they're not getting the whole message, and so it's always a struggle to use their preferences and acknowledge their preferences, but then also having some sort of look backs to make sure that we're communicating effectively. And then generally you want to not always assume that somebody's got a 6th grade reading level, but generally that's where you want to start with, in terms of the avoidance of medical jargon in particular. Okay, next slide, please. So in terms of communication strategies, I always emphasize in one of my presentations to our medical students is that the vast majority of your communication comes from nonverbal cues. So that could be eyes, and you can imagine somebody wearing a mask, how the eye deflection or reflection can make a big difference. So if somebody has eyebrows lifted, that's more disarming than if somebody's got eyebrows furrowed or lowered. It's always critical to assess visual and hearing problems, particularly for hearing. And one of the axioms, if you will, in geriatrics is to talk low and slow, not necessarily loud, although I tend to do that, probably because of my own hearing issues. But that is a consideration in older adult communication. And then typically you want to try to restrict your comments or your points that you're making for your medical assessment and plan to no more than 3 points. And a lot of times we'll write those down, for the after visit summary. Repetition is good. And so a lot of times when you do the teach back, you say, well, so what are the 3 things I asked you to do when you go back home? And if I get this kind of blank stare, I know it didn't get absorbed, but I may have presented 3 kinds of exercise to prevent falls. And by having the patient provide some feedback to me, I'll get a sense of whether it's in or not. And even these talks, for example, we know that only 10% of all the information is retained within 10 minutes of a talk. So again, transmitting information is an ongoing repetitive process. Next slide, please. Yep, so the nonverbal communication you can see with all these memes here on the right side here, but using hand gestures and rather than pointing, I always go put your hand out as a gesture of invitation rather than assertion. The big thing, at least in clinic operations, is always eye contact. And it's frustrating because we're looking at the computer, and the computer, from a provider's point of view, you're looking at the screen, you're not looking at the patient. And so a lot of times I find the patients, when I turn to look at them, they're looking down or they're looking away. And so there's just this, lack of eye contact that really can be very frustrating given the use of the electronic medical record. So finding ways in stops, huddling, getting together, doing that eye contact intermittently is one recommendation. There may be more. Next slide, please. So in the process of dealing with older adults, particularly refugees and other populations here, Indigenous health also, we need to consider the trauma history. And so is the individual a survivor of violence? So, for example, new Americans who are refugees, 75% of them have experienced some sort of violence. And I reflect even on my family's side, and particularly my wife, whose family was escaping from communist Hungary, that her father was put up against a firing squad wall right in front of the family. Fortunately, was not shot, but just to scare the pants off of him, which they clearly did. That has some reflections of trauma, that's been passed down through the family. So, and the big thing is that we also need to be considerate of is the historical trauma amongst American Indians as part of their passing on of oral tradition and history. So we'll talk about that. And I just want to give a nod to Hillary Kempenich, who's here in Grand Forks, who's one of my favorite artists. And this is just one of my favorite paintings that she's done. Next slide, please. So looking at the question of historical trauma, and again, I'm not the expert. This is just all sort of academic from my perspective, where I've tried to get some ideas collected, and I'm sure there are folks in the audience that can speak to this much more better than myself. But if we look at historic trauma, we need to consider what we would consider psychological wounds that are passed down from generation to generation. And those wounds can come from anything from childhood experiences, such as the legacy of boarding schools that occurred with Native American children being schooled in these settings with some terrible history behind them. Certainly, we are mindful of the forced removal and relocation of Native Americans, as well as the just awful history of massacres and violence, which was a way of methodology, if you will. If you read the book, the Native American History, it'll document a lot of these incidences, and then also just to consider the environmental issues that occur with whether it be oil pipes or developments. A lot of times these impinge upon native lands, and that also creates a trauma into itself. And this painting, or it's actually a drawing here, is of Frederick Remington, who was a Western artist. And the title of this particular drawing was A Questionable Companionship, between this cowboy and Native American, who, with the horse moving in the middle, is not quite sure where their destiny was. Next slide, please. So I just want to bring up these questions of microaggressions or subconscious bias. And so we're hearing more and more about that. And again, I have to plead ignorance because I'm still in a mode of trying to learn more about this. And I think a lot of it relates to the subtle and unintentional behavior or remarks I call it foot in the mouth syndrome, but there could be other ways to describe it. But these are episodes where there might be a conveyance of hostile or derogatory or negative attitudes towards groups that might be marginalized already. And so that's sort of the direction of where people think about microaggressions and the need for training in that. Next slide, please. So this is Pablo Picasso's painting of the Spanish Civil War, which kind of represents aggression, in a big way. But the way a lot of the microaggression, as I understand it, gets propagated through different expressions, and they could be gestures, they could be tone, and certainly the language. And we'll see some examples here. Next slide. So some of these examples are making assumptions about somebody's ability based upon their background or appearance, or using language that's down-speaking or implies inferiority, and then also just to be dismissive, which I think is always a concern. Next slide, please. So here's some examples. Somebody might say, well, you're so articulate for somebody from your background, or they might say, you're pretty smart for a woman, which I've actually heard before. My Harvard professor was patted on the head by a Nobel laureate and says, she says, Dr. Goodman, you're doing a pretty good job for a woman here at Harvard. And she just turned red and, oh my gosh, so very early on exposure to those kinds of commentaries. And then you can see, the additional comments here about being colorblind when you can't really be. Disabilities, are you disabled? Do you really need accommodations? Because I don't see it. So again, it's trying to get to a deeper understanding, but rather than reflecting on how we can be that, making these declarative statements. So again, it's the act of listening and trying to learn more about what is going on. This painting here, which reflects a little bit of cultural diversity, is from a Polish artist, female artist, Tamara, and so I just have this represented here as another imagery linked to the topic of discussion here. Next slide, please. So if we can reflect on what might be trauma-informed care in the long-term care setting, we need to be generally just remind ourselves that American Indian people experience trauma more often than the general U.S. population for many of the reasons that we just talked about. And this really causes both the life experiences mixed with the historical experiences, creates some really complex psychosocial issues. And so the concept behind trauma-informed care is that it ultimately is intended to promote healing amongst elders who have experienced some forms of trauma. And again, the only way you can establish that is through a dialogue. We have sort of these competing toreadors here that you can see from June Leaf, who's a more contemporary modern artist, and again, a female artist of some fame. So I included one of her paintings here. Next, yes, thank you. You anticipated me. Thank you, Bethany or Gunjan. So there's a website that presents this concept of trauma-informed care. I think the main theme is that of these 7 principles is that you create a safe environment. And so you might reflect upon what is that safe environment. And some of it may be an approach where somebody gets responds to loud noises or sudden noises, and maybe that's not so good. They get a little nervous about that. So being mindful and observant, of how people respond to your interactions. The other part of this trauma-informed care is to evolve support through families, peers, and friends. One of my favorite prescriptions, I have 2 favorite prescriptions in the clinic. Back in the old day when we used to write on a little piece of paper, I used to write a prescription for sunshine, which was one of them for our osteoporosis patients, for everybody for that matter. And the other prescription was for the oldest daughter or the oldest son to visit weekly. And so sometimes the patients would lament. I said, do you have family in the area? And they say, yes, but I never see them. I said, well, let me write you a prescription then, so they can go to their son and say, see, the doctor said you have to come visit me once a week. So I don't know how that all worked out, but it's you get the idea. And so some of the other elements of trauma-informed care is an empowerment. And so we'll talk a little bit about that. And the collaborations. And so getting ideas from people, from groups to make either changes or to address certain issues. Okay, so let's go to the next slide. So in terms of the safety element here is that really the big thing is to avoid falls. I mean, that to me is the most central part of safety for any older adult population. And there's a lot that can be said for intervening. But again, from my perspective as a geriatrician, it's a matter of efficacy, right? So you can prescribe something, but if somebody's not adhering to it so well, then pretty much all your efforts are going to be for naught, because if they fall and have a broken hip, that has some pretty bad consequences. But in terms of the safety, you always want to assess facility visitors. There might be some issues. There might be some antagonistic family members who are disruptive, and that could be of concern. And so always being mindful of both the positive and negative elements. And sometimes you can see if the older adult gets agitated after a visit from a family member, that might be brought up in a team meeting, for example. Okay, and then the other part is that just being sensitive to disrupting somebody's business. If somebody's doing something and say, "Oh, it's time to eat right now," well, in the long-term care setting, that probably needs to be adjusted a little bit. And like, I'll come back in 5 minutes, or how soon do you want me to come back? So to make sure that you don't miss lunch. So it's none of this kind of rush. We got to get you out because it's my time, not your time, right? So that's one of the other considerations of changing culture in the long-term care setting. Next slide, please. Establishing trust is important. And so certainly explaining medical procedures or things that are anticipated, and getting an agreement. So when I prescribe a CAT scan for the abdomen, I'm going to say, this is why we're doing it. And, to be honest with you, we're looking for a lump or cancer or something to that effect. And if we do find something, are you okay with going ahead with something like surgery? And they may say, no way, no how, I don't want surgery. So why do the scan, right? So you always have to test the waters and see with whatever you're doing, whether people agree with it firstly. And then if they do agree with it, whether they're going to follow through with the information once they get it. Next slide, please. So when we talk about peer support, that could be a variety of things, including transportation for community events, shared stories. That would be another element. And just as a nod to Dr. Holloway's program on telegacy, we're always looking for older adults and elders to participate in his program, where as an intergenerational project where students, both undergraduate and graduate students, interview an older adult and get their life story, and then they create what's called a legacy book. And so that's just another methodology for getting reminiscent therapy, actually. Next slide, please. In terms of collaboration as part of the trauma-informed care, it's important to ask people about their life before the admission, as well as if there's anything that's bad that's happened to them, and to just be as open as possible for that. Any kind of healthcare plan should be discussed and revised, importantly, like what's working, what's not working. And that would be true of just about any project. You always want to know what's working and what's not working. And so too, you want to figure that out with the older adult. Encouraging interactions with staff, try to avoid isolation. We did a survey once where 60% of the older adults in long-term care felt isolated in some manner. And so it's very prevalent. And then the last point here is to try to accommodate each elder's desire for a daily routine. So waking and sleep preferences would be a good example. Long-term care should not be like a military barrack, lights out at 10 o'clock. But again, you don't want people who are nighthawks disrupting other people. And so it's always a delicate balance, as to how you guide patient-centered care. Next slide, please. I forgot to put the artist here. This is Ansel Adams, the famous Yellowstone and Yosemite photographer. So the other question we want to address is empowerment. And part of that is to make these connections with the healthcare providers and the caregivers. And we talked earlier about accommodating language preferences and aligning the right level of conversation to the educational level of the patient. And then also to delve into some, if the older adult is interested, into their spiritual beliefs and other faith-based activities. And so one of my favorite questions in the clinic when I see older adults, I said, "Are you church going?" And a lot of times I'll react when they say, "I used to be." So to me, that's really a moment of transition as to what matters to them. I said, "Well, so what's different now than before?" And then you start getting their history as to why they transitioned. And in some cases, they reclaim that spirituality. I just had a patient, in fact, yesterday, who's now going back to volunteer, with this church group. He had become very isolated, lived by himself, had a lot of psycho-emotional problems because he was just very isolated. And we're we're making progress. Let's put it that way. So just by an invitation towards reclaiming some of their, like I say, spiritual activities, an important conduit for healing. Next slide, please. You also want to provide a voice and choice. And so the idea is that there should be different ways for people to express themselves, whether it be in writing, through a family member, or through a residence council or anything of that nature. Privacy is always important, and sometimes that's difficult to do because a lot of times in long-term care, the rooms are shared, and so there might not be much privacy. And certainly I know in the hospital settings, they've gotten away from shared rooms, they're individualized rooms. And so too, we hope that long-term care will move in that direction. And this is, again, another painting by Georgia O'Keeffe, who spent a lot of time painting different kinds of flowers. So it's a nice representation here of that. Next slide, please. So trauma-informed care strategies is to include training of staff and to incorporate these strategies into facility policies, and also to think about it as part of quality improvement. We call this quality assessment and project improvement, or program improvement, better known as QAPI in nursing home lingo. And so that's an important consideration. And the next slide, please. I wanted to address some issues about some disparities. And believe it or not, I snitched the slide deck or this picture from earlier in our presentation by Dr. Trottier. And, it's part of this invisible race concept that we learn about with Native Americans. And it's important to kind of look at what the data is. And I want to be careful and be very strongly careful of not overstating what these disparities are, because there's a lot of strengths, and I think a lot of times we emphasize the weaknesses, and we don't always focus on the strengths. And so I'm going to show you what I mean by that here shortly. Okay, yeah. So thank you. Next slide. Yeah. So one of the disparities in the older adult population is more falls with injuries, and I'll just reflect. I said I don't know the reason for that, other than I would just speculate that because of the higher incidence of the slightly higher incidence of diabetes, that there might be more neuropathies in the feet, and so that numbness and inability to get your sense of balance may be driven by that factor. Next slide. And so here we have again that more diabetes. So twice as much as the white population in Native Americans for diabetes. But again, it's not the majority, right? Everybody says, oh, Native American diabetes, and it's 16%. So that's not the whole population. So I just want to emphasize that part of it. Next slide, please. So this is the positive side of things. So from the data, if you look at cardiovascular deaths, for a given disease, such as coronary artery disease or strokes, that the numbers of deaths are, well, almost 33% less in American Indian populations than they are in comparable age-matched white populations or African American populations. So I think this really, again, for me, is, in terms of population health, is a very positive sign. And what is it about the resiliency amongst the American Indian population in face of multiple chronic conditions that allows them to sort of defend themselves against these chronic conditions? So it's kind of to me, it's an interesting question going forward. Next slide, please. So it's the same issue with cognitive decline. We heard earlier that there might be more instances of forgetfulness reported by Native Americans. And so we need to reflect on what can we do in a preventive manner, as well as what we call secondary prevention, which means how do we prevent progression from moving forward? And I'll just emphasize that current research suggests 3 interventions, which is good blood pressure control, cognitive stimulation, and exercise. So those are the 3 main ones. Next slide, please. Yeah, so this is the another indicator of resiliency amongst Native Americans, particularly with chronic disease. And so once a chronic disease management program is implemented, you will see here with this green curve, look at how much improvement there is amongst the population who were presented with an evidence-based chronic disease management program. So again, the population, or for population health, Native Americans are much more responsive than other populations for improving or what we call secondary prevention. So I think that's just a real strong indicator of resiliency and potential. Next slide, please. Just to describe the social isolation, it's a big issue. And I know Dr. Holloway in particular has repeatedly pointed out that prolonged social isolation is about the health equivalent of smoking 15 cigarettes a day, which is not too good. And so just we want to emphasize that this should be an issue that we always have on our front burner. Next slide, please. So there are some models about what occurs with social isolation. I just want to bring your attention to this concept, which is not proven, but it might accelerate the rate of aging. And then this is totally speculative. And the question is that by intervening with social isolation and loneliness, can we slow the rate of aging down? So again, it's a conceptual framework that that I've been formulating to think about how psychosocial interventions can actually impact the biology of aging. Next slide, please. So some of the practical things that we can do is to gather around both exercise, group exercise, and hobbies, philosophy groups, intergenerational encounters, which Telegacy represents from our program here at Dakota Geriatrics. Senior centers for sure, and senior centers are not for everybody, but again, encouraging those interactions. And I've already mentioned about a prescription for routine family visits. Next slide, please. Okay, so there's some resources here. National Indian Council on Aging. So they have resources on how to prevent or deal with social isolation. I think we have a few more resources here. Next slide, please. Yep, so this is from CMS, so Tribal Nursing Home Assisted Living Facility Directory. So I just wanted to point that out as another resource. And this is just recently came out in last year. And then what I'd like to do is take questions, but also just to summarize that cultural diversity has this tension between what we call assimilation and then also being celebratory for our differences. And then it's important, no matter how we move forward in our provision of caregiving in healthcare, that we continually increase our awareness and training to help our colleagues basically recognize some of the challenges that occur with biases, and to ultimately try to promote a more inclusive and equitable practice in healthcare. So I think that was my last. Oh, I was just going to mention Claude Monet here. So you see these two ladies on the edge of the cliff, and the poor lady on the left, there's always been some speculation as to whether she's about ready to fall off the cliff. And so people really, back in the 1800s, when this painting came out, got very nervous about this whole situation. And so I use this as a painting to represent that tentativeness, or that balance between what we call, inclusion, assimilation, and then celebrating our differences, that we're always kind of on the edge of trying to figure that one out.